Hello, everyone. I'm Brandon Hawker with Open Minds Market Intelligence Team, and I would like to welcome all of you to today's Circle Elite Executive Roundtable, How California Health Plans Will Change Their Contracting Models and Network Management Under CalAIM. Today's roundtable features Dr. Rafael Gonzalez Amezcua, Chief Medical Officer of Aetna's Better Health of California, and Bo Hanneman, Regional Vice President of Local Engagement and Plan Performance at Anthem Blue Cross. Dr. Rafael Gonzalez Amezcua is again the Chief Medical Officer for Aetna Better Health of California. There, he develops, implements, and promotes population health, health equity, strategies, policies, and programs that drive the delivery of high-value healthcare for Aetna's California Medi-Cal business. Dr. Amezcua's focus is on improving the care of vulnerable populations. His areas of expertise include elder care, complex care management, health equity, federally qualified health centers, PACE program, and utilization management. He has served in various leadership capacities from Northern to Southern California at Onlook Senior Health in San Francisco, where he was the clinical faculty at UCSF, as the Associate Medical Officer at Sequoia Community Health Center in Fresno, California, as the Medical Director at the UCSF Fresno General Internal Medicine Clinics, as Regional Medical Director for Senior Services at AltaMed Healthcare Services, as Interim Executive Director and Chief Medical Officer for Bienvenidos Community Health Center, and as the Founding Medical Director for Brandon Centers for Senior Care, a PACE program for the Los Angeles Jewish Home. Most recently, he served as a Medicare Medical Director of the LA Care Health Plan, where he oversaw all aspects of the Medi-Cal Medicare dually eligible program, Cal MediConnect. Dr. Amezcua received his Bachelor's of Science degree in psychology from the University of California at Davis and his medicine degree from the Rosalind Franklin University of Health Services, the Chicago Medical School. Bo Hanneman currently serves as the Regional Vice President of Local Engagement and Plan Performance for Anthem Blue Cross. In this role, Mr. Hanneman provides oversight and leadership for quality management, marketing, community relations, county management, and local engagement teams across California. He is also responsible for the operational performance, contract oversight, and financial performances of the LA County Medi-Cal line of business, which serves over 500,000 members annually. In his 6 years at Anthem Blue Cross, Mr. Hanneman has also held statewide responsibility for directing and overseeing operations, business strategy and alignment for special programs such as long-term services and supports, health homes, whole person care, palliative care, CalAIM, and social determinants of health. Mr. Hanneman has over 19 years of experience in program development and implementation within Medicaid business programs in both the public and private organizations. Prior to working at Anthem, Mr. Hanneman served as the Senior Manager of Home and Community-Based Services at LA Care Health Plan. Mr. Hanneman has also spent over 11 years working for the Los Angeles County IHSS Public Authority. Mr. Hanneman is a graduate of the University of Missouri, where he earned a Bachelor's of Science degree in Business and Public Administration. Moderating today's roundtable will be Richard Lewis III, Vice President of Open Minds. As Open Minds Vice President for the Western region, Mr. Lewis has extensive experience as a behavioral healthcare administrator, business development specialist, and innovator of new service lines. Mr. Lewis has served as a psychiatric hospital administrator for the Charter Medical Corporation, Assistant Director of Behavioral Health at San Bernardino County Department of Behavioral Health in California, as Director of Strategic Development for Behavior and Addiction Medicine at the Southern California Hospitals Prospect Medical Group, as Executive Director of Strategic Development and Planning for Pathways at Molina Healthcare, and as Vice President of Government Operations at College Health Enterprises in Los Angeles County. Mr. Lewis graduated with a Bachelor of Arts in Psychology from Whittier College. Before we get started, a few housekeeping reminders. Your audio will be muted during today's briefing. However, we encourage you to submit any and all questions you may have using the question box located to the right of your screen. We will present all audience questions at the end. Finally, the slides and recording from today's briefing will be available on the Open Minds website by tomorrow. Richard, I'll turn it over to you.
Thank you, Brandon. Thank you for that introduction for our panel today. And we can go to the next slide. Today's webinar, and first I'd like to welcome all of our attendees today, all of our virtual guests that are not only from California, but from all our elite members all over the country. Today's really kind of a snapshot of where we are in California's CalAIM initiative that started this year. We're hoping to talk a little bit about kind of the first 6 months, contracting for new services just started at the beginning of the year, as this is our first year of about a 4 or 5 year journey to California's transformation of their behavioral health Medi-Cal system. We're hoping to learn today a little bit from our panelists about the health plan experience over the last 6 months, working with providers and how that's been going, health programs and cost development of these new contracts, what that's been looking like with providers in the health plans, and just overall some successes with regard to the process services that have been developed and delivered. Next slide. One more. So I'm just going to take 2 seconds to introduce the California Advancing Innovative Medi-Cal, or what we call CalAIM initiative here in California, especially for those folks who are viewing from other states. And really, this is California. This is a process that many states have gone through previously, and I kind of feel like we're one of the last states to go through it. And that is really taking our Medicaid or Medi-Cal system here in California, moving it from a fee-for-service model to a more value-based, performance-based model of care. Next slide. The key reforms, that affect all 58 counties here in California, and now are bringing into the fray, in a way that we haven't done before, more of the health plans into being able to work with our Medi-Cal beneficiaries, are really to have the managed care plans, be able to create a more person-centered population health strategy. We're going to talk a little bit about how the 14 non-medical community supports or in lieu of services are part of that strategy. We'll talk a little bit today about enhanced case management, enhanced care management, which is also being rolled out this year. Again, part of that integrated care management program to guide the treatment of behavioral health, primary care, and drug and alcohol services, among other things, for our more complex Medi-Cal beneficiaries. And really, it's probably the biggest change for us is the change of reimbursement models here in California, from cost-based reimbursement or fee-for-service contracting with our providers in the community to more of a performance and value-based system, which is a big leap for us and for anybody in any state. Next slide. Just some high-level things, again, in the first month here, and with regard to, the goals of the initiative, we are seeing in this first year, the movement from fee-for-service to value-based reimbursement approaches. Some of these programs that are being contracted for remain fee-for-service, but many of them are being developed and contracted for under value-based models like case rates and per member per month types of things. We're seeing the rollout of the population health strategies from the health plans with regards to care management of complex populations. Right now, focused on our adult populations. We're looking at, for the first time, health plans addressing more formally social determinants of health in the community supports that our panelists will talk about right now, and really. This is the first year of really seeing the health plans really playing a more formal role in providing services for our SMI adults, and next year our SED children and adolescents. Next. So I'm not going to spend too much time with regard to enhanced care management because we'll let our panelists talk about it. The list of the services that are part of that are listed here on the side, and I think the main thing of note is more the idea that this is a new service that is available to specialty provider organizations and community-based organizations, CBOs here in California, and we're in our 6th, 7th, 8th month of really trying to get those contracts and programs rolled out. Next slide. We'll talk a little bit, we'll hear from our panelists again about how they're contracting for and what their expectations are for the community support services, which again are more transitional in nature, but are addressing more of the social determinants for our complex populations here in Medi-Cal beneficiaries here in California. Next slide. With that brief intro, I'd like to just hand it over to Dr. Mescua from Aetna.
Thank you, Richard, and very appreciative to be part of this and to be invited, and also to be part of this panel with Bo, whom I know well and have learned a lot from. So essentially, I'm an internist, and this will be a sort of a physician's perspective, so to speak, on ECM and community support services, and but also from the plan's perspective, as we aim to help address the needs of these populations that are quite complex. So if we can go to the next slide, please. So as Richard said, a few elements of what enhanced care management and community supports are. As Richard mentioned, the department has designed this particular benefit to help support people with complex healthcare and social needs. And I'll talk a little bit later about this, but essentially complex folks are complex because they're complex. And often they create substantial burden to themselves, to their families, to the system, and to the system they interact with, whether it's a primary care provider, whether it's a community agency trying to deal with them, and ultimately, of course, the system and the payers, and then the outcomes to themselves in terms of quality outcomes. It's quite a complex set of circumstances with deep roots into how they ended up there. It aims to sustain and expand this concept of being person-centered, whole person care coordination. And I think those, there's some who, are of the opinion that the system has been not necessarily person-centered. And we focused on what the system has, what the system can do, and what the system will do, but not necessarily what the person needs as a whole. And I'm talking about whether it's physical health, mental health, oral health, and then now we know about the impact of social determinants of health and family dynamics, etc. And so the whole goal is then to expand on this person-centered, whole person care coordinated approach. And it's designed to be interdisciplinary, meaning that one person, one entity alone may not be able to address all those complex issues. And in person care management, traditionally from the plan's perspective, care management had been traditionally telephonic, but the goal here is to get as close as possible to the patient's environment, to the community, and to identify distinct populations of focus, those that have certain characteristics. They will require a distinct approach, different resources to address the primary needs. And also, the department seeks to advance, how we're going to pay for this. How we're going to fund the services that traditionally have not been part of a health plan milieu of benefits, and invest also in community organizations that have the trust, that have the knowledge, and sort of the expertise at the community level. How do we make sure that they are supported to ensure we do, the work towards better outcomes? The department is also bringing resources through incentive payments to build and to meet certain capacity building milestones, such as enhancing the delivery system infrastructure, the work equity, the workforce capacity to do the work that needs to be done for these complex folks. And to build upon needs assessments, we need to ensure that we identify what are the salient needs, what are the priority needs of the folks we serve, and then be able to fill those gaps where gaps may be. If we can go to the next slide, please. So as Richard mentioned, there's some core services that are part of enhanced care management. Definitely, the number one, before we get to this point on the first bullet point, is really to identify either through claims or referrals, who is that population of focus and how did they come to be under that population of focus. We identify those folks, and prior there'd been a term called the telephone engagement list, or some kind of a list of names. Then we select and do it outreach and engagement. We need to find folks in the community where they live. It's no easy task. We need contact information. Some folks may not have contact information, could be homeless or transitioning from living situations. They need to be outreached, and there's substantial effort, and it's quite an effort to be able to do that, to identify and then engage. So we need their cooperation. We need for them to say, yes, I will participate then in this process. Second bullet point is doing a comprehensive assessment of what their needs are. Again, speaking about physical health, mental health, oral needs, social determinants, financial issues, etc. And then doing that assessment and then developing a plan, how we're going to address those issues. And then it needs to be prioritized. And with the patients and the members' engagement, we need to get their perspective, their community perspective, their family's perspective, to be able to make sure that we're successful with this management plan. And the plan is a basis then to coordinate the care. I think as a physician, I'll tell you that if a patient has, let's say, 4 chronic conditions, that patient actually may be seen by 15 different physicians in the community, plus imaging studies or lab or other tests that need to be done. So in the period of a year, you may have lots of places and things that need to be done. But if there's an acute event such as hospitalization or an illness, then you almost exponentially expand on the need of all those services. And so that coordination to ensure that it's addressing the right needs for that person is very important. So enhanced coordination of care is very important. Then making sure that, let's say, when there's no acute events, they still have the chronic conditions, make sure that health promotion is in place, making sure that we look forward in terms of how best we can prevent the exacerbation or an illness or an untoward situation. And then comprehensive transitions of care. And these transitions are important. And I'll tell you an example. As a physician, when a patient comes to the hospital for a condition, and at the hospital, of course, there's a lot of medications and treatments and specialists that will help that patient resolve that medical issue. And traditionally, we've known that once they leave the hospital, then the treatment has been successful. Good news, that pneumonia, that heart attack, whatever the case was, has been cared for, treated, and now you can go home. But in reality, for certain people, that transition from hospital to community is probably the most dangerous step, because they have new medications, there's more follow-up, and we don't know the home situation. We don't know if they're able to follow through. So that transition is very important. The supportive member in the family is also very important. We know that, depending on the complexity of the condition, the family may or may not have the wherewithal to be able to support and also burden the family, either resources or other issues. And the last, I think, is the area where there have been a series of community support services that traditionally have not been part of the health plan milieu of benefits. And this is, I think, is not only is the whole CalAIM and healthcare management is very innovative, I think this component takes it that step further, but it could be one of the most complicated. And as you listed, Richard, those community services were listed there. If we can go to the next slide, please. So again, as a physician, my perspective on complex patients is that they come at you like a tornado of competing needs. And as a physician, so I have a patient in my office. I have 15 minutes to care for this patient. And I have a set of medications, a set of vitals, a set of conditions that I need to address. But how they ended up there may be based on social determinants, all these other needs that are behind it. But as a physician, I don't have the time or the capacity or the resources to be able to address those things. And I only have 15 minutes. And half of those minutes sometimes are dealt for, the electronic health record or other issues. So then brings it down to less. And patients, when they're this complex, whatever entity they encounter first may carry this image of a tornado, meaning they can disrupt the system. So that's the image that I have when I think of this complex populations and what we need to do to be able to address those needs. Those needs often are competing with each other, such as, not necessarily in Medi-Cal, but let's say sometimes I don't have enough money to buy a medication, therefore I'll go without it. But when social determinants, if I don't have a car, if I need a car, if the car needs repaired, if I don't have money to pay the rent, I may not go see my appointment. I may not eat the meals that I need. The comprehensive assessment and care plan needs to address these issues, and it takes time, and it takes more than just one person. It takes this multidisciplinary approach. So this is the image that I have. If we can go to the next slide, please. So a little bit about the highlights, what we've experienced at Aetna Better Health of California thus far, because in healthcare management, it continued the pilots that were in place before, like health homes and whole person care. And one of the highlights for us is we were able to transition 100% of our members who were in this pilot in December 31st or January 1st, 22, they transitioned. So that was a success for us. No one fell through the cracks. We were able to build an easy to use financial grid for our with codes and modifiers so that we can partner with our community-based entities to ensure that we keep focus on a financial level, how we pull down this benefit. We customize a platform to assist the enhanced care management and community support providers regarding claims processing. And I'll talk a little bit more about this in terms of building the capacity of these community-based entities where they have the passion, the knowledge, and the trust of the community. They may or may not have the wherewithal to be able to deal with a large health plan and all the intricacies of contracting and claims, et cetera. Our authorizations were started in quarter 4 of 21 to give us a heads up in terms of laying the foundation for the benefit once it became live. So we started early. And care management in our department oversees enhanced care management, and they follow standards. So we train our CM staff on those principles of utilization management, such as identifying the criteria, identifying who doesn't meet criteria and what we need, and then turnaround times to ensure that things are being done promptly, effectively, and accurately. And since we launched enhanced care management, the membership for us has grown approximately about 130, 150%, which is good. And now as a start, so now we're seeing it to be taken up a bit. If we can go to the next slide, please. So success cases, we had 72-year-old transgender male that transitioned, that was released from incarceration and was homeless. And just as in, I think someone who's older, someone who's is going through is transgender, incarcerated, and now homeless. Those are distinct different challenges. And ECM and community support services and the staff and our partners in the community were able to not only do the outreach and the engagement and develop the trust of individuals and address the needs. So this member transitioned successfully into transitional housing and is now living in this housing, awaiting now permanent apartment. And in between the effort and the participation and the collaboration of our community agencies and the plan and our staff to be able to ensure that this member got what he needed was very important. If we can go to the next slide, please. So in the next slide, I think as I started to reflect what we've learned, I broke it down into our staff, our providers, and our leadership. So I think, again, these are complex issues, and ECM, community support services, is actually a rather complex set of steps and criteria and things that we need to do. And we're bringing the planned care management team with the community. And I think we always are looking for ways to ensure that both entities understand where the responsibilities start and the responsibilities end for better collaborative effort. So we have this IDTs where we come together and we discuss cases, but it's important that our staff don't take over the care management and the coordination, nor that our community partners don't assume that we will do that. I think that is something that we're always on top of, trying to figure out how best, because otherwise it creates confusion and burden to the staff. Also, anticipating needs of our staff when there's turnover. We live in a world now where, the great, what they call the great resignment, or the great people are resigning, and so staff turnover is inevitable. I think it's important that there's a system in place when there's key turnover in place that things don't fall through the cracks, and be able to build. I'm so sorry, there's a bit of a typo there. Build on skill set to help guide and support our providers. So we always constantly are looking again to that principle of the building capacity, and then guidance regarding escalation trigger points. At what point in the discussion, instead of continuing to discuss, we say, hey, we need to escalate this to a different level. Those are things in terms of how we support our staff, in terms of working with our ECM partners. Next slide, please. And on the next slide, the focus here is what we've learned about our providers. Again, and I think, I worked in a clinic that I often say was probably one of the poorest clinics in LA. And because we were poor, we didn't have resources, but we had passion. The community trusted us. People could come in and tell us their problems, and we would help. We often, the staff, would pitch in to get somebody some clothes. So there was a high degree of trust, but we didn't have the capacity, the resources to bring in staff with expertise on grant writing, on contracting with huge plans, managing claims with sophisticated plans or large plans. So I think it's very understanding that the providers of the services understand the role that they need to make, anticipating against staff and turnover needs, enhancing contracting claims processes and skill set, enhancing PCP buy-in, and in terms of I talked about we build an easy to use guide, and we have this educational component, and we make ourselves available at any one time. I think the goal is how can we enhance that process so that we anticipate kind of the needs and the capacity, and then fill in from our end any way we can to help support that process. Enhancing PCP buy-in, I think as a physician, again, this is a perspective from a physician. I remember my days in the clinic where I would have 30 patients. And I'll tell you, I'm busy with just addressing the medications, the conditions, the vitals, making sure that the diabetes is under control, making sure that congestive heart failure is under control. And the last thing I needed is a care manager who wanted to take an hour of my time to explain to me how they were going to help, something or other. It's a false belief that is not useful. In my perspective, it's definitely shifted in that regard. But I see it now that physicians don't want to be part of it, but their buy-in and their participation is so important. So we need to articulate the benefits of the primary care provider, because if we address issues upstream on social determinants, mental health, etc., those are things that can help the provider do their job more effectively. Better control the diabetes, better capacity to take medications, etc. So I think being able to articulate that benefit and have enhanced PCP buy-in is very important, something that we actively are working on. If we can go to the next slide, please. And so this is a complex issue. It's an important component of helping to improve the healthcare of our members. But it's complex, got a lot of moving parts. And whereas in my brain, I think enhanced care management, community support services, of course it makes sense. We need to do better at that. Once you start looking at the parts, there's many parts, multiple players. So I think it's very important to have a kind of clear understanding of the end-to-end process, and to make sure there's closed loop referrals, to make sure that the referral ends in a connected referral and an outcome as expected. And if not, what can we do to ensure? So the end-to-end process is very important. Identifying and monitoring internal key milestones, depending on the relationship, depending on the staff that you have, and depending on the partners that you have and their various capacities. Not necessarily the larger milestones of CalAIM, but internal key milestones need to be identified to ensure we stay on track. Understanding the range of provider capacity levels. I talked about my own personal experience with a very poor clinic. I would say that we were on the lower range of capacity, but we're full of passion. But I was lucky enough that I was able to connect at that time with folks who could help us. At that time for us, it was getting an electronic health record. We didn't have the wherewithal or the capacity to build a robust electronic health record, but we got great help and resources to be able to bring us up to speed at that time as a very poor clinic. So in that regard, also, it's very important that the plan understands where is the need and where do we invest. An intervention grid as per provider capacity or situation. So for us, as I mentioned, we didn't have capacity for electronic health record, but we were able to get help on that. Next slide, please. And then in terms of the leadership, I think leadership in terms of the expertise and knowledge and authority to make changes, mutual understanding from the plan and the partners of where's going to be that intervention, and not just leave it to the staff to perhaps not be as effective in the intervention, and develop a structured process to help deal with the most complex cases via what I call a complex case war room, where those most complex cases, most challenging cases, there's a discussion, a mutual discussion, and then very quickly get to a kind of an intervention. And with that, that is my presentation. I want to thank you for this great opportunity, and thank you. The end. Thanks.
Thank you, Dr. Mesqua. I think we're going to move right into Bo Henneman from Anthem. Bo, it's all yours.
All right, thanks, Richard, and thanks, Dr. Mesqua. So if we can go to the next slide. I'm going to flip through these slides pretty quickly. So whoever's on the fast forward button, keep that finger ready, because I'm going to go fast here. So this first slide is, just a general overview of Anthem. We have been serving the Medi-Cal population in the state of California since 1994. Currently, we cover 29 of the 54 counties within California. I think it's 54 counties, but we're in 29 counties spread throughout California, and serve about 1.4 million members in Medi-Cal. So that is only our Medi-Cal line of business. If we go to the next slide, I did want to start and just give a quick overview of how things are going so far with these programs that we're talking about: enhanced care management and community supports. Enhanced care management, I think we've covered between Richard's slides and Dr. Amezqua's slides, like what ECM is and what types of services are covered. I think it's important to note that, as we've rolled this out under CalAIM, it's rolling out in different phases and different waves throughout the state. And so on January 1st of this year, enhanced care management did go live as a benefit in any county that previously had health homes or whole person care pilots in place, and for only certain populations of focus. So let me start with the populations of focus, because I don't think that's something that we covered, but there are 7 distinct populations of focus, or different kind of eligibility pathways to get connected to enhanced care management services. Those include individuals who are high utilizers, so they have a high inpatient or ER use; individuals who have severe mental illness or substance use disorder; individuals who are homeless and have other chronic conditions going along with that; individuals who are looking to transition out of a long-term care facility back into the community; individuals who are eligible for long-term care placement but need assistance coordinating their services so they can stay living at home; individuals who are re-entering society from jail or prisons, so the jail re-entry population; and then children and youth is the 7th one. And so all of this is moving at different times. And starting in January of this year, it was really the first 3 populations of focus that went live in certain counties. So that was the high utilizers, individuals with SMI-SUD, or individuals who are homeless. And for Anthem, that meant 10 of our 29 counties went live with ECM services in January. In July of this year, so a little bit more than a month ago, those 3 populations of focus expanded, and ECM went live in all counties throughout the state. So for Anthem, we are now live with the enhanced care management benefit in all 29 counties, but only for those 3 populations of focus. Starting next year, ECM will expand those populations that are focused on long-term care diversion or long-term care transition will be going live in January of 2023. And then in July of 2023, the jail reentry population of focus and the children and youth population of focus will go live. But as you can imagine, while there's 7 different buckets, the reality is nobody sits in just one of those buckets, right? Like, even when you think about the jail reentry population, which is going to be a big one coming in July of next year, a lot of those individuals who are going to be part of that ECM are also either high utilizers, or sometimes they're homeless and they're discharging from prison back into the street, or they have SMI-SUD conditions that have to be treated. So there's a lot of, not as clear cut as you fall into one of those 7 populations of focus. But we did go live with the program in January, have built out a network of FQHCs, community-based organizations. We're contracting with county behavioral health departments, hospital providers, a whole variety of different types of providers to do enhanced care management. And the intent is that, this is an intensive face-to-face intervention. As Dr. Amezqua says, this is not like the traditional telephonic-based case management approach that health plans have done. It's really working at the community level and having that intensive care coordination happen with these members. We did transition in January. We had about 4,500 members who grandfathered in from the health homes and whole person care pilots in those 10 counties. And since then, the program has grown. We have about 6,200 current authorizations for enhanced care management. And if you think about that, because remember I said we have 1.4 million members, and today we have 6,200 members in the program. Now, I think our projections are that, that's going to double over the course of the next 12 months, and we'll probably get to about 12 or 13,000 before we hit steady state. But that's a very small percentage of our total membership, right? And that's not everybody that's eligible. That's everybody who's been engaged and has a current authorization in place. But as Dr. Amezcua said, these are our most complex members. And I like that tornado graphic that he had, because, these are, not members who need basic care coordination or just need connection with PCP or just need, some simple behavioral health interventions. They have multiple complex issues that have to be managed through this program. So that's where we stand with enhanced. Yeah, go ahead, Richard.
Can I ask a quick question? And Dr. Amezcua mentioned this a minute ago with regard to Aetna's growth up by 130%, and then you're looking at your numbers here. I'm curious to know, for the plans, are you doing any kind of formal client recruitment? How are you getting these clients over? Is there any kind of recruitment solicitation, some kind of a campaign that plans are doing to engage clients and get them enrolled or get them linked to these services?
Yeah, so I mean, it happens in a couple of different ways, Richard. One of the key things that we've done is and all plans have had to do this. We have built out algorithms to identify which of our members are potentially eligible for ECM. And those algorithms are complex, and when we did health homes, we were primarily looking at claims data, but now we're looking at claims data, we're looking at SDOH data, we're looking at community health data, we're pulling in county behavioral health data. We've got all these different data sources feeding into these algorithms. We identify these members, get them out to our contracted providers so that they have a list to work off of so they can do proactive engagement of those members. However, we're also relying heavily on referrals from our contracted providers and working to educate our larger provider groups, our county behavioral health partners, and so forth, because the reality is, for some of those populations of focus, when you look at homeless as an example, we're working to get connected to each county's HMIS database, their homeless management information system. But there are gaps there, and we don't have all of that data coming in today. And even if we did, only about 30 to 40% of individuals who are actually homeless are in some of those systems, right? And so, we're really relying on that strong referral base too, which is a big change. And health homes, as Dr. Amezcua said, we got a list from the state. We really worked off of that list and went from that. But we're now looking at different data sources and really relying on this referral process to get members engaged.
Thank you.
Good question. So if we go to the next slide, I'll talk a little bit about community supports. This slide looks similar to the one Richard had up. This lists the 14 different community supports. One thing that I'll call out is we did implement this statewide in January of this year across all 29 counties, but it looks very different from county to county. So the state set these up as optional services. Optional not because they think, maybe a health plan will want to do it and maybe they won't, but because there's really this understanding that it is going to take time to build out the infrastructure for some of these services in each of our communities. And so you think, with an organization like Anthem, where we're serving 29 counties, and you look at the third one from the bottom there, sobering center services, that's complex. There's only a handful of sobering centers throughout the state. And you even look at a county like Los Angeles, which is very resource rich. There's a lack of sobering centers and a lack of capacity to do this, right? And then you look at some of our other counties, some of our rural counties. Butte County is a good example where, we're working with the community, and Sutter Yuba is another example, and really identified that, this is a priority for the county and they really need this, but there's nobody providing these services today. And, you can't just snap your finger and say, hey, we'll pay you if you submit claims, just set up a sobering center service. It doesn't work like that. It takes a lot of strong engagement in the community, bringing different partners together, and could be a multi-year process to stand that up. So from county to county, this does look different. Some counties we have 4, I think, is the minimum amount that we would have in a county, 4 of the 14 services. In some counties we have 12, but each county looks different. The plan is that between now and 2027, we are building out capacity to provide all 14 of these services across every one of the counties in the state, right? Like that's the ultimate goal that we're working on.
And
Where things
well,
stand,
question,
yeah.
as you're adding those, as you're adding new services, how are you notifying the providers? How are you notifying the potential new providers that this is something that you're looking for?
A lot of community engagement, a lot of outreach. We have standing meetings every month and do this jointly with the other health plans in each county. But we meet with the county. We have what's called roundtable discussions, more community-based engagement discussions going on in most of our counties. We're doing direct provider outreach. Anthem has monthly webinars that we host. So it's a variety of different ways, but I think it's the messaging is ongoing, meaning that it's not a matter of, hey, we're launching this new service next month, and so let's send out an email to everyone and let them know, right? Like it's looking for a variety of ways to let people know that, hey, we've got these services live. Because again, with a lot of these, we're doing some data mining and trying to identify these members, but really relying on referrals coming in from the community for some of these services. As of today, we did have 1,400 members who grandfathered in from whole person care and health homes to receive these services. We've done about 2,000 authorizations year to date and have about 107 providers in our network throughout the state. So things are starting to pick up. I will say every month our number of referrals is getting higher and higher. But it's a program that really is going to take another year or so, I think, to fully hit its stride and be materialized in a way where we're really getting this out to a good chunk of our members. So if you go to the next slide, quickly, I'm not going to go through all of these. This is kind of core provider requirements and expectations, is because I mentioned, we have 90 ECM providers, 107 community supports providers, but we're not done. Like we continue to build out our network and add new providers for these services. You do have to go through a vetting process, be enrolled with the state of California as a Medicaid provider. I think Dr. Amezcua called out this third bullet, invested at a leadership level. And I want to reemphasize that because I cannot stress that enough. Like I've seen it time and time again. We have organizations who think, what, we already do some sort of case management service. We should just be able to get reimbursed by the health plan. And so let's sign up and just do it, right? And that doesn't work because, you don't have that full leadership investment to be willing to staff up and build out capacity and make the organizational changes that are needed to be a part of this program. It's going to fall flat. And you really have to have that type of investment from the leadership, get them to understand that, hey, this isn't, some standard program you've already been doing services for. It's going to be a modified version of that because there are a ton of requirements that CMS and the state have put on us that we have to pass down to the providers. Things like billing a health plan a claim for some of these services. You look at those community supports, and an example would be medically tailored meals, right? So we have tons of community-based providers who have done home delivered meals for years and years, but they've never submitted a claim to a health plan before, right? And that's a big change to build out that infrastructure and that capability to be able to do that. And you have to have that investment at the leadership level to be able to do that. The only other one I'll point out here is that last one, which is provide culturally competent services. This is a huge emphasis with the state right now, health equity and looking, across the state at all the different cultures represented in the state of California within the Medi-Cal population, the different languages spoken, the different cultural backgrounds and beliefs. And, there's really an emphasis on making sure that we are getting these services making them equally accessible and equally engaging across all of those cultures. And so, that's one that's really critical. I'll use medically tailored meals as another example because I think this is a good one. We've had some providers where it's like, yeah, we've got a menu of 20 things. And it's like, okay, well, what about somebody who's Vietnamese or what about somebody who's from one of these other cultures? Like, like if you're deeply embedded in another culture, like you don't want hamburgers and pizza like my kids do every day, right? Like there's other types of foods that you want, and you should be able to get access to the food that you want, not just say, yeah, somebody's going to give me food, so I'll just eat whatever they give me, right? And so I think that illustrates that, you know, you have to be able to you know, really serve across multiple cultures. This next slide, if we get to that one, you know, this just lists some general challenges from the provider perspective, going through the contracting process, getting authorizations, being able to submit claims, doing the training, all the reporting, everything else. It is a big change for providers, and I think you have to be willing to go through that change. I think if we skip to the next slide, you know, this illustrates, you know, more of what we're doing as a health plan to help with that. And to be upfront, like those challenges and this change, it's not just providers. It's a change from us at the health plan perspective as well. You know, we've had to modify everything that we're doing. You know, I know one of the focuses here is on contracting. We had to completely rethink how we're approaching some of our contracting. You know, I think starting back in when we started talking about CalAIM and just going to my contracting teams and saying, okay, look, here are the types of services we need to have we need to contract for. You know, Anthem's a huge organization, and we've got, you know, 20 different contracting teams, and they're all looking at me going like, yeah, my team doesn't contract for that type of stuff, right? And so, you know, we had to build out a new contracting process specific to this program. We had to build out a new process for credentialing providers, because, you know, some of these provider types, they don't align with standard medical type of credentialing processes that health plans have in place. So we had to build a whole new vetting process, right? And so it's been a lot of change on our side. You know, on the top of this slide, a lot of local engagement, working with the counties, working with community-based providers to get their input, working closely with the competitor health plans. So you know, we do a lot of work with Aetna in Sacramento. That's the one county where we have overlap. I think it's also a good example because there's 5 different health plans in Sacramento, but we do a lot of coordination to make sure that, you know, we're building things in similar fashions and working together to make things easier for providers to contract for these types of services. We've also, you know, changed and built out, you know, our infrastructure to be able to better support providers going through this. So, you know, we've built out teams which include regional program managers, dedicated clinical staff for these services, who really understand what these services are. They're doing the authorizations, they're doing case audits, they're doing care coordination. We've built out additional provider representation staff. So, you know, we don't just have the same team members that are working directly with PCPs. You know, we have dedicated staff working on these programs within our provider team and working to help walk through issues, right? So a lot of different things that we've done there. The last thing I want to touch on are these last 2 bullets: capacity building and incentive and value-based payment models. And if we could flip through, I think I'll skip the next slide. I'm assuming Richard will send these slides out. The next one is just kind of the link to get started if you're interested in being a provider. But if we go to maybe, yeah, I'll pause here quickly. But, you know, I think Dr. Amesco mentioned this, you know, the state, to their credit, you know, we did raise it. Hey, when we went through these other pilots like health homes, there was a lot of need to do infrastructure build, and the funds weren't there. And that was a problem for a lot of people. And so to the state's credit and to the governor's credit, they did inject a lot of dollars into the state budget to allow for incentive-based capacity building, which is funneling through the health plans and allows us to make investments in our local providers so they're able to provide these services. And so if you go to the next slide, you know, this kind of represents what we're doing with those funds, really looking to make investments in three different buckets from my perspective. So one is one-time capacity support for ECM and community support providers. So this is, you know, if a provider needs funds to build out their data infrastructure, they need to get connected to a health information exchange. They're not working with an electronic health record, or they need to make changes to their electronic health record so that they can better document what they're doing under these programs. They need assistance with setting up billing processes. They need to add staff, which comes at a cost. You know, building out that staffing capacity, whatever they need from an individual provider level, we are able to make investments into that provider up front and not just say, yeah, contract with us and you'll make money off of these claims later on, right? So we're able to give those lump sums of money up front. The second bucket is looking at kind of community-based needs. I mentioned sobering centers as a good example in a couple of our counties. And, as we're working with those counties, we realize that, hey, what we need actually is to bring in a consultant and bring in a group of people to work across organizations and help stand this up. And this has been identified as a priority. And so we're using these funds to start to make those types of investments. Also to make investments in different types of health information exchange or social health information exchanges in some of our communities. And then the third is really working with our ECM providers to add value-based payments on top of what they're already earning as an ECM provider. So if they're hitting specific measures, they're executing on the program, they're getting their assessments, their care plans done, they're hitting their enrollment targets, really providing some incentive on top of that. So I will say that there's a lot of money flowing through. A lot of this is just started happening. It's an intense process that we've built, intense on the health plan side, I should say, for providers that we're working with to tell us what their needs are and for us to funnel this. We're currently getting kind of the first round of capacity funding out the door, which is about $8 million across our counties, not including LA. LA is actually another, I think, $2 or $3 million. And there's definitely more funding available to make these types of investments in the community. But I think that's critical because, when you look at those other slides and you look at what it takes from an organizational level to get engaged and to do these services, again, it takes a willingness to change from the organization. It takes, the partnership with the health plan. And I think we've built out the infrastructure internally to be able to make that partnership happen and to provide extra attention to these providers as we're building out our network. And then the third piece is this funding to build that initial capacity and make sure that organizations that are coming on board have what they need in place to be able to be successful in engaging these members and connecting them to these services. Mm-hmm. And I will stop there.
Great. I mean, that was right on, and it answered a lot of questions that actually I already had written down. But quick question, Brandon, I know we have a couple minutes left. Do we have any questions from any of the audience?
Yes, we have a ton of questions. Richard, if you check your chat, I've sent them all to you, or I could read them as well.
You go ahead and read them because I'm not seeing them on my screen.
Okay, so first, as there are limited CBOs that are ready to provide these services, has the state plans considered a pool of funds for growing the CBO base, perhaps through established state nonprofit CBOs?
So I think what you're talking about is, and maybe I'm wrong. If I'm wrong, retype the question. But I think what you're talking about is what we sometimes refer to as a hub and spoke model, right? So there is definitely a shortage of some of these providers in some of our areas. And I think when I look at our rural counties, it becomes very challenging because there is some administrative overhead to be able to be a part of this program. And if you're working in a rural county where there's only going to be a handful of people engaged, that total reimbursement sometimes doesn't make up for that administrative overhead that has to be done, right? So we have been having conversations with community-based organizations to try to align where they're either working as subcontractors of one other organization who's taking on that administrative burden, or they're partnering to figure out how can they work together to share that administrative burden and limit the cost, right? So those conversations are starting to happen. I don't know if I have like a good model where somebody's figured out exactly how that works, but I think it's critical, especially in the rural counties where the numbers don't justify standing up a whole new organization or a whole new program within an organization.
Okay. We have another one. It says, I work for an affordable housing organization with a robust supportive service program. We currently provide these services to our residents. My concern is becoming a Medi-Cal provider and the additional staff that will be needed as far as admin, fiscal, Q&A, etc. Also, the burnout that my staff could experience from additional admin duties.
Yeah, I think, we try to address the issue. There's funds available for building capacity and infrastructure, and those incentives are there. Also, the community-based organizations can draw upon other funds that the state has directly exactly to build that. And I think to us, at least our commitment and our learning is to be able to help those staff that are frontline staff that can have that administrative and the complex case burden. How do we guide? How do we escalate? How do we support? Not only at the plan level, but at the community-based level, precisely because you have the expertise and the exposure and the trust. We'd like to emphasize that and then build that infrastructure around it through incentives and other resources.
All right. It is now 2 o'clock. So for anyone that didn't get their question answered, I will be sending all the questions, all the unanswered questions, to Dr. Amezcua and Mr. Hanneman. We'll get answers from them, and then we will email all of you personally. I just wanted to thank everyone for joining us for today's web forum, and I'd like to remind everyone that the slides and recording will be available tomorrow on the Open Minds website. For the full Circle Elite Executive Roundtable series, which is also available on demand as part of the extensive Open Minds library, please go to openminds.com and select events, and then also it's available on the Open Minds YouTube channel as well. Please join us for our next roundtable on Thursday, September 15th at 1 p.m. Eastern Time for our Circle Elite Executive Roundtable, Bringing Care to Consumers Through Street Outreach, the Access Services Case Study. This session will address homelessness in America and how Access Services and Tower Health join forces to reach consumers in the street during this 1-hour event. Deborah Curtin, Senior Director for Behavioral Health, and Mark Borsch, Director of Program Development, along with Access Services, Casey Finoglio, Community Health Wellness Program Manager for Pottstown Hospital, Tower Health, and Dr. Holly Van Blier, Emergency Medicine Physician for Tower Health. And they will be sharing their model for reaching this disadvantaged population, their financial model, and how to overcome the systemic issues driving these consumers from treatment. Also, we have how to build value-based payer partnerships, an Open Minds executive seminar on best practices in marketing, negotiating, and contracting with health plans, which is part of our executive education seminar, and that is next week, August 25th at 1 p.m. Eastern Time. For a full list of upcoming roundtables or to register for the September 15th event, please visit the Executive Web Roundtables page under the Events tab at openminds.com. Thank you all.
Thank you, Bo. Thank you, Dr. Matt. Thank you all for attending today. Thanks, Brandon.